All right, welcome everyone to another session of the group chat. We're so excited you decided to join us today. Just some quick housekeeping to go over. There will be a Q&A at the end of the presentation. So if you submit questions into the Q&A bar at the bottom of your screen, they'll go to me, and then our speaker will answer them at the end of today's presentation. This presentation is being recorded. However, no attendees will be identified. And as a reminder, the information shared in this presentation is not medical advice, but we will be providing additional resources at the end of today's talk. So with us today, we have Dr. Marcia Klein-Patel. Dr. Klein-Patel currently serves as the system chair of the Women's Institute at Allegheny Health Network. She co-founded the inaugural midlife medicine practice at AHN to support women as they navigate menopause. She's a true expert on this topic, and we are excited to have her here with us today. And so without further ado, I'll pass along to her.
Well, thanks for everybody for taking your lunch hour with me. Happy to have you all join me. I am also, as Bree said, this is the only practice I've ever done. It's the practice that I came in out of my residency doing. For me, this is a real opportunity to focus on healthcare as a window into the rest of our lives. I've been really excited about the fact that menopause is finally part of the national conversation. But I also think in some of that national conversation, it's really hard to sort out like what is true and what is not true. And I'm hoping today that I can give some, I'm going to say like fundamental basics by which you can think through all of those things that you're hearing and reading. And certainly, as Bree said, this is just general advice. Anything we do individually may be different based on someone's symptoms or their personal concerns or their background medical history. But I hope that we can have a starting place for us all to be able to have shared dialect as we try to help people be healthy through the midlife. So when we talk about menopause, fundamentally, I think about this as sort of two different things. Perimenopause, or the menopause transition, is that like 1 to 5 years around the time of your last menstrual period. It is characterized by less regular periods and the onset of hot flashes. And menopause is defined by 1 year after you're done bleeding and can occur anywhere and be normal between age 40 and 56. And so why do we undergo menopause? We all have as many oocytes as we're going to have actually when we're 20 weeks in utero. And even at that time, then our ovarian reserve starts to go down, and then it's stable until we start having our reproductive lifespan. So we start having menarche and we start ovulating every month. And so gradually there's a depletion in the oocytes that are available. And so your brain asks your ovary, I say, to like release an egg. And at some point, your ovary is like, no, I'm tired. I don't have anything left. And the brain keeps yelling louder and louder. And in the early perimenopause, this is fine. It works. Your ovary gets on board and it gives what it has left. But then at some point, it no longer can release that egg because there are no active or follicles left. And so we stop releasing eggs. And so hormones are the communicating system between the brain, the ovary, and the uterus. For me, I think it's really helpful to think about the uterus as being the sign for what's going on with the hypothalamic pituitary ovarian axis. So if we're bleeding and we're bleeding every month, then I know relatively where people are in their cycle because they're bleeding every month. So as we get closer to our final menstrual period, the pituitary hormone FSH will continue to go up and estrogen will continue to go down because we're not releasing follicles every month. There's another chemical inhibin that plays in this role. And so after menopause, those things stay steady state. We'll hear a lot of people talk about like hormone balancing after menopause. For me, that's a little bit of a misnomer because if you can see in that bottom graph, they are stable. They're doing what they're doing. But doesn't mean that we necessarily feel well. And I think that that's a very different conversation. And then I always press the buttons and have to figure out where to move myself forward. So if we then take at that stage before menopause, then break that out again into two parts. There's the part that's right before we stop bleeding, and then the part before that. So in early perimenopause, For most women, this will start somewhere after 40, maybe 45. If they are not using any hormonal methods for contraception or for any other reasons like heavy bleeding, people may notice that their cycles will be 3 to 5 days closer. So instead of being a 28-day cycle, they might be at a 23-day cycle or a 25-day cycle. They may notice at the time of ovulation that they have more breast tenderness, more mood changes, and more headaches. These are specifically to the ovulatory time period. And so if they're occurring all of the time, then they're not related to the cycle. If they're only occurring in that time period, the 14 days before your period, then they are. And some of this is again because the pituitary is yelling at the ovary and the ovary is like yelling back and is making it work out. Later in the perimenopausal transition, the pituitary is yelling, your ovary says like, leave me alone. And so we start to space out our cycles. We'll start to have ovulatory cycles, and we'll start to skip. This is the time of the most wide hormone fluctuations that people will see. And again, on average, 3 years before the menstrual period can be 5, but the worst of those symptoms tends to be about 18 months before people are done. So the symptoms are caused by these like change in that late perimenopausal and the hormone balance, but no single hormone is actually the culprit. Most common symptoms in the perimenopause are gonna be hot flashes and night sweats, irregular bleeding. I'm gonna pause there on irregular bleeding. It should only be a cycle length difference. So people should not have heavier bleeding. They should not have longer bleeding, and they shouldn't have intermittent, unscheduled, like I bled 3 days and I bled 3 days after that, and then I bled 3 days after that. Those things should all prompt you to see your OBGYN. But if your cycles are, every 36 days and they're lasting 2 to 3 days and they're relatively light, that's actually really normal in that late perimenopausal time swing. Mood changes in the late perimenopause, we tend to see a little bit more decreased mood. Patients who've had prior premenstrual symptoms of mood disorder or have had postpartum depression are at increased risk in the perimenopause. I do ask all my patients about that, and do make sure you tell your provider if you're worried that you could be at risk of a hormonally mediated mood change. People can report poor sleep and fatigue. That poor sleep is generally caused by those night sweats. And then that precipitates fatigue. Joint pain is real and can be really limiting symptom for some women. And then the irritability, again, related to poor sleep and some hormonal fluctuations. And I mentioned the headaches earlier. So when we need to be treated during the perimenopause, and frankly for us in our practice writ large, it's what are our symptom control goals for quality of life? I bring the discussion about premenopause or perimenopause and postmenopause separately because those treatments that we commonly use for menopause are not all effective in perimenopause. So you'll see that in perimenopause, we'll tend to use birth control pills or something that can override that hypothalamic pituitary ovarian axis in a way that hormone therapy cannot. Hormone therapy treats the hot flashes, but they can't keep your cycle on regularity. It doesn't change ovulation. And so it doesn't change the communication, which is really what we're going for in the perimenopausal time period for this symptom. We do oral contraceptive pills. You'll also hear me call them combined oral contraceptives or non-hormonal use of hormone therapy. Progestins or progestogens, when we use the word progestogens, we mean synthetic progestogens. Antidepressants. So antidepressants can be used either cyclically because the mechanism of mood disorder is different. It is the impact of the metabolite of progesterone on the amygdala of allopregnanolone, and so that blocks that. But if people are having symptoms all month, we will prefer to use antidepressants for the whole month. We cannot overemphasize how much like taking care of your mind body is important in this, and we'll talk about this a little bit later. making good choices about eating, sleeping, and exercising, and techniques to manage stress. Paced deep breathing actually is really helpful and has been shown to have good data for this, and actually also for hot flash management, which I think is really important. And cognitive behavioral therapy has also been shown to be helpful for hot flash management. When we think about the menopause, I alluded to it a minute ago, it's a different time period. It's your last period. No bleeding should ever occur again. If you have been 12 months, and that's the definition, and have had no bleeding, and then after that bleeding recurs, you again need to proceed to your OBGYN, actually relatively emergently. Well, most of those reasons are fine. There is a small risk of cancer associated with postmenopausal bleeding. We always just want to make sure everybody is safe and okay. It's diagnosed in retrospect. As I said, the average age in the United States is 51, 52, depending on ethnic background. And again, it's that steady decline of ovarian hormones until you really don't have any ovarian hormonal activity. Your adrenal glands are still making hormones, and any fat tissue is also still making hormones, but the ovaries themselves are making very little. So I hope that helps sort of like set the table of how we think about those things separately. The symptoms of menopause, I've been sort of saying that I divide them as to primary and secondary. Those things that we know are directly related to lack of estrogen in that time period are hot flashes or night sweats, vaginal dryness, and muscle pain. Those are directly related to estrogen deficiency. I think maybe I'll take a minute to describe like a hot flash, because while after menopause we can have a little bit less heat tolerance, or I say we have heat intolerance, which has been particularly great this last week. They're not whole body in general sweating that lasts a long time. It is a sense of heat or warmth that usually starts in the chest, goes up through our neck, into our faces, which is unfortunately very public, especially for many of us who might be on meetings all the time, and then quickly dissipates in a feeling of cold afterwards. If I put a temperature thermometer on our chest when that happens, we could measure it. It is a real vasodilation. It is not just the symptom of getting hot, it is getting hot. But if patients say like, oh, I've been hot for hours, I tend to think about like, what medications are they taking? What's their blood pressure doing? What's their blood sugar? When was the last they've eaten? What are they doing diet-wise? And just making sure that there aren't any other non-ovarian hormonal causes for that. Some people are less bothered by their night sweats. They just use a fan, but day sweats, but the night sweats can be really challenging and can really impact sleep quality. And so we talk about staying cold at night, and I'll talk about that in a little bit later. Vaginal dryness occurs because two reasons. One, there's a decrease in secretions, and the second is there's a decrease in the thickness and rugation, or the bumpiness of the vaginal mucosa that someone can appreciate, particularly if they have penetrated vaginal intercourse. And then the muscle and joint aches, they tend to be symmetric. So if somebody says, just my right ankle hurts, I injured it when I played volleyball when I was a kid, that's probably arthritis. But if there's like bilateral knee, hip, shoulder pain, that's actually probably menopause, and that can be really limiting for some people. The next group I say like go together with the primary symptoms. So if people have decreased libido, people have increased vaginal dryness, if they're not sleeping well, if they're not generally feeling well because of the hot flashes, that's going to make libido go down. They might have difficulty concentrating, again, primarily related to sleep. There is one specific menopausal change that gets back. So anybody who's going through this, I'm going to give you reassurance that you are fine. It's anomia. So if you're like, I need a pen, right? That will come back, but the specific anomia related to menopause is true and not related to sleep. All of sort of the other brain fog and fatigue is primarily related to sleep. And if we can help fix sleep for people, even if we're doing it with a combination of medications or mind-body stress reduction techniques, it can really improve memory. Mood swings, again, can be both hormonally mediated, as I said, some increased depression in a 18 months before and 18 months after the menopausal transition. But, look, we treat those consistent with how we would treat mood disorders outside of the menopausal transition. There's a lot of talk about weight change, and I think I disappoint my patients all of the time on this. One is to say, actually, it's true, right? We might have been in a pair our whole lives, and people are going to say, I have more weight distribution in my abdomen than I had before. That's true. When you look at large studies around weight gain, and you look at both international and national studies, it probably is not the menopausal transition specifically that relates to weight gain. It's probably more the aging process and loss of muscle mass. I know that that is not a kind thing to say, and I sort of always apologize to my patients. Certainly, are there some studies that say like 3 to 5 pounds maybe can be attributed to menopause? There is. In general, if people have 20 or 40 pound weight gain, 20 to 40 pounds of weight gain, I really do think we need to be looking for other reasons and other methods of treating that weight gain, because I know it can be really distressing for people. Hot flashes and night sweats are the most common presenting symptom. 25% of women won't have them. I tell them congratulations and don't tell your friends. 75% of women will, but 25% will be truly impacted by the amount of hot flashes and the night sweats they have. The peak is in that first 1 to 2 years out. For women who are not on any like breast cancer medications or any other medications. They can be related, they can be ranked as like mild, moderate, severe. For us, that's the disruption and the number is how we come to some decision making about how much those are bothersome. And then, as I said, they can last 6 months, in general 2 years. There are studies that for a small percentage of women, they can last 10 years or more, really in about that 2% range. I think I'm also going to take a pause about some misunderstanding about hot flashes and night sweats. Let's say I go through menopause, and I go through menopause at 52, and I have hot flashes till I'm 55. And then I start having hot flashes again at 65. That's not ovarian mediated. That's not estrogen mediated. That's probably mediated by something else. And that's a health care warning sign for us to go look for other causes of hot flashes. So while hot flashes in this time frame, I always say, are predominantly mine, I did it. When we start to see them outside of the final menstrual period or really remote, or they have completely resolved and then they come back, we do look for other causes for hot flashes. Sex after menopause. Look, many people say this is a great time. Pants optional, no pregnancy, no bleeding. That said, some women can be really bothered by pain with intercourse, which then decreases libido. The other thing that some people will find is that they can have increased time to orgasm. I don't address this later, so I'll just talk about it a little bit second here. For those patients who know increased time to orgasm, we will say warming lubricants to the clitoris, foreplay as a must, and if at all possible, orgasm prior to penetration. But those things can all be really helpful for people who notice increased time to orgasm. There are FDA-approved devices for orgasm. They are not covered by insurance, despite being FDA-approved. The two best study that I had the most experience with are EROS, E-R-O-S, and FIERA, F-I-E-R-A. And so those are really helpful. And so if you are finding that you are struggling in this area, this is a reason to come see a gynecologist. And we'll talk about how you can see one of the menopausal gynecologists a little bit later. All right, menopause is not a disease. It doesn't have to be treated. Our goal is to help patients who are not feeling well feel well, okay? People deserve in their lives to feel well. But if you're like, no, I feel great, this is fine, awesome, and I'm excited for you, right? And it doesn't have to be treated just because you've hit menopause. And so our goal is symptom relief. Broadly speaking, when I'm counseling patients in the office, I start from lifestyle modifications through non-hormonal medications to hormonal medications. Lifestyle modifications we should all be doing. Pulling our hair off the back of our necks, having short hair, having fans on our desk so we can cool down. Short sips of ice water will help us. Break a hot flash, and then keeping the bedroom like painfully cold, right? So 60 outside of recent heat waves, where I think many of our air conditioners probably couldn't do it, really keeping that bedroom down to like 64 degrees will be really helpful. Things like chillo pillows or cooling blankets can be helpful. And a fan at our feet specifically. I know a lot of people have the overhead bedroom fans. Being able to have that fan at your feet and stick your feet out at night if you get hot and then pull them back in can be really helpful. Exercise will help. It helps build like cardiovascular health and vascular health. And while we might have hot flashes while we're exercising, overall our hot flash burden will improve. Dressing in layers, and then, limiting things that can be triggering. So alcohol can be triggering for a lot of people, particularly, wine, things with sulfates in them, and spicy food for some people can be a trigger, not for everybody, but if you find that that's a trigger for you, it's probably worth stopping. Again, behavioral techniques, we talked about pasty breathing. Some people call that square breathing. They really do shorten the hot flash duration and also shorten the distress around those hot flashes. Meditation and relaxation can do that as well. And there's good data that hypnosis can help. I don't have a particular hypnosis recommendation in Pittsburgh, but it can help. When we talk about herbs, in general, the data for herbal supplementation for hot flashes is really very specifically, not otherwise overall health. Hot flashes are, the data really doesn't support, except for with the example of black cohosh. The thing about black cohosh is because it works, it actually is hormones. It's a selective estrogen receptor modulator, and we should treat it as such. And I do recommend my patients, if they're going to use that as their preferred method, to try to limit it to 6 months. And again, in my patients who have breast cancer, we don't use it at all. Acupuncture can help some patients and is great for joint pain. So if your only symptom is joint pain, actually acupuncture would be a really good option for you. There are 3 FDA approved and studied treatment options for hot flashes that are not hormones. So the antidepressants, things like Effexor, which you'll see most commonly in our office, Paxil, but even Zoloft, Prozac, those can all help with hot flashes. Gabapentin, which is a neurotransmitter, and fezolinetant. Fezolinetant is the newest medication on the block. I'll talk about that in a second, but just first to say that like all 3 of these will all decrease hot flashes about the same, about 50%. And so really gets to be about which of these things will meet your symptoms goals, your like other medications that you're using, your like, look, some people think like one thing is not tolerable to them, or another might be able to tolerate it. Like, so gabapentin can have some sedation. You have to be able to stay in bed long enough. Some people might have had nausea, for example, with an antidepressant before. So just really figuring out which side effects people can tolerate. A word about fezolinetant. So it's been out about a year. We are really excited about that medication, but I'm going to asterisk that for a second. The things that make us less excited about it is cost. And so depending on your insurance, it has to be prior auth. It may not be covered at all. The cost is $20 a day if not covered. And so as a practice, that like makes me feel a little bit bad, but some people have good coverage for it. It is the first medication that we have specifically at the receptors that cause hot flashes. Those are the KNDy neurons, and it's a KNDy neuron antagonist. Does have some side effects like nausea and headache that you can see with antidepressants as well. There are and has been shown to be increased LFT, so liver function test aberrations or changes in patients taking fezolinetant. And so And so we would say, like, you have to get, and by directions, you have to get liver function tests before you start this medication. So if any of you are on it, please do make sure you get your liver function tests, and then every 3 months thereafter to make sure that there's no metabolites causing any liver damage. I would say for us, those are the limiting factors. It is got a long list of medication contraindications, which are not readily accessible by the company's website. And so, if there are any providers on this call, it's a CYP2A. It is a very long list. It's actually contraindicated with vaginal estrogen. And so while I think it's a great medication and no patients are happy on it, just be very careful to make sure that we are helping and not harming patients. In general, I'll answer comments at the end, but I see this one about supplements. Vitamin E, I love in the vagina, actually. I think it's fantastic. Systemically, I don't know that it helps as much. And there's a question about evening primrose oil. It's good for breast health, has no support for menopausal hot flashes. But for patients who have cyclic breast pain, evening primrose oil can be really helpful. But not so much for hot flashes. For hormone therapy, again, this is a risk-benefit discussion with your provider. Estrogen is the main hormone that we're using to minimize hot flashes. But progesterone is needed in our patients who have a uterus. And so when we think about the use of estrogen, estrogen is preferred to be given transdermally or through the skin. The transdermal route is safer because it bypasses that liver metabolism, right? And so estrogen has a metabolite when taken orally that can increase the risk of heart attack and stroke. Transdermally, we do still say that there is an increase of heart attack, stroke, or blood clot, but that's less than if we were taking it orally. So in our practice, you will always see us use transdermal only. Also in our practice, I say that we prefer the patches as a primary delivery system because there are so many options that we can almost always find one that's covered by your insurance. The creams, the sprays, and the ring, there's all one. They're expensive. The manufacturing doesn't, sometimes goes down. Unfortunately, during COVID, most of Europe is actually on the mist. And then that manufacturer went down and like all of the UK was out without hormones. And so now you're in lockdown with no hormones. I bet it was really pretty. For progesterone, again, we need that progesterone to protect us from uterine cancer. If I give people estrogen without progesterone, we will get uterine cancer. And someone commented about the type of patches. I think you guys can't see it. Some people do have better luck with some patches than others. And so Mylan is a brand that we do have good response to. The progesterone is oral because topical progesterone is not well absorbed. And so if I'm using it to keep people from getting uterine cancer, I actually really want them to have good absorption. The downside of progesterone is estrogen and progesterone together do increase the risk of breast cancer. That breast cancer risk continues to go up the duration that you're on it, right? And so the longer we're on hormone therapy, the more our breast cancer risk goes up, which is why you'll hear us in our practice sort of talk about the shortest amount of time for the benefit that's needed, right? Because we're really trying to keep people from having that risk. We have always believed that progesterone, sort of the natural form of progesterone versus progestogens, which are testosterone derived, was more breast safe than the testosterone derived. That data finally has come in and appears to continue to be true, but that's why we do it that way. Testosterone, we really use tremendously sparingly. There is no FDA approved form of testosterone for women in the United States. It really has shown the best benefit for women who have had iatrogenic menopause related to maybe like surgery or cancer, endometriosis, who are very remote, from the menopause transition. And again, we use it for a really short period of time, primarily because there is some blood clot risk associated. There's some hematologic risk related to it. And any changes around unbalance, like voice changes or clitoral changes, tend to be permanent. Um, Also locally, vaginal estrogen, I joke that like I use, except for my patients with breast cancer, I kind of use it with impunity. I don't have a favorite, and it doesn't have any of those risks that I just talked about related to systemic hormone therapy. So what it does is thicken the vaginal mucosa and increase the secretions to make sex less painful. That is the only thing that's approved for, right? So if you're like, I feel great, except for sex hurts, this could be a great option. I also say, because I don't like to use things that are expensive for my patients, we'll just play with your formulary until we find one that works and you can, and is not expensive, right? I don't like people to pay $3.50 for something when I can find something that's $15 and works for them just as well. So I tend to believe those things. I will talk a little bit about, I think, the bladder in this section, and we'll talk a little bit about breast cancer because I see them come up. Bladder can be a couple of things. It can be bladder irritants. It also can be vaginal dryness. And so sometimes people have hot flashes, they wake up and then they have to go to the bathroom because they're awake. Sometimes it's the vaginal dryness that causes people to feel like they have to have increased urinary frequency. And then sometimes it's things that are bladder irritants that maybe didn't bother us before we were in menopause that are bothering us now. Things like, again, alcohol, unfortunately, spicy food, unfortunately, but also acidulated water, right? Like a lot of us are putting like lemon in our water because it tastes good. The bladder hates it. And so, thinking about those things. And then again, like broadly speaking, for hormone therapy, family history outside of a known gene mutation of a breast cancer is not a contraindication. Now, if somebody has a strong family history of cancer, so what that would be is a breast cancer or uterine cancer, age under 50, or two second-degree degree relatives with either of those things, or anybody with ovarian cancer, male breast cancer, or metastatic prostate cancer. I do recommend all my patients get genetic testing to make sure that we aren't missing anything that could put their health otherwise at risk. And so that we can like help them move through that time. So family history is really about the number, degree of relatives, and any other risk that we can mitigate for you. Again, treatment, I think I've now said this like 6 times. Treatment does vary by individuals, and no one treatment is right for you. And this particular slide's actually old for me. And I think I'm going to spend a minute on that. Sometimes I have patients come into my office and they say like, well, my friend said I should, or my family said I shouldn't. I think those are worth an actual discussion with your doctor about what's right for you. And I think bizarrely, like people in the lay public have really strong opinions about what we should do about our hormone management. And I think, that really has to be like a driven decision about your personal risks, your family health history, and your own preferences about, again, what risks you're willing to accept and what risks you're not willing to set. And there is no one right answer. And so you should always, with your physician, discuss your options, your risks and the benefits of your treatment. We say this pretty regularly, borrowed it from Dr. Sandy Chapman, who's at UT Dallas, who is a neurologist actually and studies brain health and menopause. And so we say all of health is eating well, sleeping well, having good relationships, and exercising. If you have those 4 things, you actually have health. And we can manage all of the other symptoms around it, but they really are a crucial beginning and understanding to how we are safe in menopause. I'm going to go back and we'll talk about some of the other questions that we have in the chat box at the end. Just some things to think about living healthfully. When I started the menopause practice, I think people were really surprised, right? Like, well, why not obstetrics? And for me, it really was like patients walked into the office. They're like, I want to take good care of myself for the baby. And I was like, okay, that's nice. In this time frame, we walk into the office like, all right, now how to take care of myself. And for me, that's way more fun. right? Like, how do we live this last half of our lives as like healthfully as we can? So look, smoking is not great, right? Increased heart attack, stroke, decreased life years. Actually also increased risk of things like cervical cancer and vulvar cancer amongst, like, we think of lung and bladder, but those things as well. Exercise regularly, everything counts for me, right? So if like I walk my dog, 2 miles a day, that's gorgeous. If you do mall walking, that's fantastic. If you do chair yoga, fantastic. We really do need to be moving our bodies, and whatever work we can do to eat well and be in a healthy weight is also really helpful. We know these sound easy, and then I always say to my patients, if it was easy, we'd all be like exactly where we wanted to be every time. And so we acknowledge that this is really not easy. Um, what a lot of people ask me what to eat. Um, the best source of nutrients is in your diet, right? So we do believe in careful supplementation, but we really prefer people to get as many of their macro and micronutrients in their diet. We say like basically Mediterranean, low red meat, low saturated fat, high fiber, high vegetables and fruit, any of those sort of superfoods that have a lot of omega-3, blueberries, and the four greens, the darker, the better. Um, the only FDA study on, actually, excuse me, NIH study on diet and heart health is actually the DASH diet. And you can find that just by going to dash.gov, dash.nih.gov. And it is right there, and it's the only studied diet plan that helps promote cardiovascular health. And so we'll often recommend our patients take a look at that. But fundamentally, it's the Mediterranean diet, really thinking about a balanced plate. And I often have, you know, patients say like I eat really good quality food. That's like amazing, and it's a great place to start. But thinking about that, like sort of like whole balance and overall like amounts of each of those portions is also really important. It is important to get regular preventative care. So seeing an OBGYN every year, establishing care with a primary care provider if you have not already done so. Needs will change as we continue to age. And it's hard for me when I have patients who we say healthy by omission, which is they haven't received care, and then they come into care and there's kind of a lot of work that I give them, and it can feel really overwhelming. And things change. And there are, as more research comes out, and I'm not a primary care doctor, I think there's new data on lipids, like those things are important. There's new data on alcohol, right? So we should not be drinking as women more than 2 drinks in any given sitting. And those are 6-ounce glasses of wine, not 8 or 12. And those really do increase the risk of cancer. And that's actually changed quite a bit. We should really be thinking about if we drink alcohol daily, just 1 drink a day to minimize those health risks. And that's actually been a big change over the last 10 years for women. Preventative care, we need a lot of things, right? So we need our regular mammogram and a clinical breast exam. You need a pap test. The pap test frequency has changed, which has been, I think, in our lifetimes, has been a big adjustment for patients. So as long as your HPV test has been negative, you've never had any high-grade disease, that is actually 5 years, and we do recommend an HPV test. Screening for colorectal cancer age has gone down to 45. We do recommend everybody get colon cancer screening who is low risk. Hopefully, if you are family history or at elevated risk, we have gotten to you before them. The two tier 1 recommendations for colon cancer screening are colonoscopy and FIT test. Colonoscopy, we will say, is the gold standard, because if there are any polyps or precancerous lesions, we can take them out and prevent cancer later. The FIT test is an annual home stool test. It saves almost as many lives as colonoscopy, but you really have to be committed to doing it every year. And it doesn't do any of the preventative care that we talked about with colonoscopy. We got to make sure we don't have elevated blood pressure, that our cholesterols are normal, keep our vaccines up to date. and thinking about when we need to start being screened for osteoporosis. In a general risk population for women, that's 65. But if you're on steroids or you have other medical comorbidities, have received chemotherapy, or have had a parent, specifically a mom or a dad that had a hip fracture, all of those are reasons why you might need a DEXA screening a little bit earlier. And if you've ever fallen in adulthood and broken a bone, that actually also does require a DEXA scan. And so make sure you're discussing any additional screening with your healthcare provider. For our patients who are over 50, if you've ever smoked more than 20 pack years, we actually do recommend a low dose screening CT scan to look for evidence of lung cancer. So we say, what is a healthy life, which is and we just like straight from the WHO, and we couldn't agree more. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. And that's our goal, to help our patients every day. This is our practice. So it's Dr. Prairie and I. We have two nurse practitioners, Deanna Nemec and Kayla Vanelli now Redmond. And Dr. Kathy Struggs will be with us here in a couple weeks. And so we look forward to her joining our practice. And I hope that was helpful for everybody. And then they got some like baseline understanding of how we approach, menopause.
Thank you so much. That was great. We had lots of questions get sent in, so we'll start working our way through those. To start off, you mentioned you can kind of track if your periods are becoming irregular as you approach menopause. We had a question that said, what are other indicators, or how do you know if your periods are becoming irregular if you're on birth control and maybe don't have a regular period?
Great question. All right, so for those patients who are not using birth control or hormonal contraceptions or a Mirena IUD or didn't have a hysterectomy, right? There are period tracker apps, and they're free. And some of them are even FDA approved. So Clue is one of the FDA approved period tracker apps, is recommended by our organization, which is why I tend to recommend it. And actually, Bree, let me go ahead and flip one more slide while we're talking. But if you are on hormonal contraception, if you have a Mirena IUD or you've had a hysterectomy, it can be a little bit harder. For those patients who have hormonal contraception, if you're on continuously, frankly, we won't know. And if you're asymptomatic, not to be cavalier, we're sort of okay about it, right? If you're like not having hot flash and night sweats and you're, feeling great, like fine is fine. For patients who have a Mirena IUD or a hysterectomy, I tend to ask them to track their symptoms a little bit. So I combine their like symptom tracker with their age, right? So if you're 50 and you're having hot flashes all the time, like it's probably menopause. If you're 46 and you've had a hysterectomy and you have cyclic breast symptoms, it's probably perimenopause. And so I don't generally, and not to say not never, but don't generally order labs because they are accurate on the day you get them, but not accurate over time. They bounce around, particularly in the perimenopause, right? And so any given day, you could look premenopausal, you could look postmenopausal, and that could vary within 2 days. And so I tend to think for patients who are not having menses, that the symptom tracker combined with age just ends up being far more relevant than any of the other things. Bree, what else you got?
Someone asked, if you get night sweats but no hot flashes, does that mean you can have one without the other, or the hot flash is coming down the road?
Yeah, no, some people just get them at night, right? Absolutely, you can have one and not the other. And I'm sad because they're easier to manage during the day, but absolutely, one can happen without the other. And to some extent, I think people will say to me, the hot flashes, even if they are having them, just aren't impacting their quality of life. What is impacting their quality of life is the fact that they're waking up. And so, those can be more bothersome. On the night sweats, there are some things that are high alert for us, right? Night sweats should be just as I described the day sweats. But if you're waking up and you're like, I'm soaking wet and my sheets are soaking wet, we do need to look for other causes because in general, like we do worry about risks of, diabetes and thyroid disease, but also lymphoma, right? And so while that is very rare, I think if your night sweats don't kind of fall into what I described, it is probably worth seeing somebody.
And sticking to that topic, is there a connection between hot flashes and an increased urge to urinate during the night?
Yeah, I think I tried to answer this one a little bit. What we think, right, is that you have a night sweat and you're awake and you're like, oh, well, I might as well go to the bathroom, or I could go to the bathroom. And it's probably the night sweat that's waking you up. And that if we help people sleep better, they would wake up and go to the bathroom less. But do limit fluids 2 to 3 hours before bedtime. No alcohol, no spicy food, no lemon in your water. And really just try to go to bed with as empty of a bladder as you can. But for most women, that's not to say everybody, but for most women, it's primarily the night sweats that wake you up. And then you're like, well, I'll go to the bathroom.
And then another question came in. If someone had menopause symptoms and then had a hysterectomy and now kind of still experience those same symptoms, is that something you see, and what might be causing that?
Yeah, I mean, look, the uterus is just the bystander. Your ovaries and your pituitary are marching on, right? And so absolutely, removal of the uterus, if it was the uterus alone, is not going to impact the other sort of menopausal symptoms. And for patients who have had a hysterectomy, who are premenopausal, they can go into menopause on like 18 months up to 2 years earlier than they might have otherwise. But if you had hot flashes before and you had hot flashes after, but the uterus is removed, there, menopausally, hormonally, there's no difference. I hope that answered that question.
And do treatment recommendations change for women who have a family history of breast cancer?
Yeah, it just depends on how many relatives, which relatives, and what people's risk tolerances are, right? Most breast cancer is actually not familial. But that said, for some people, any risk might not be tolerable, right? So this really gets to be about who in your family had cancer. Were they tested for any genetics? Should we test you for genetics? And that can really drive our conversation. But family history alone really doesn't play a role. It only plays a role in how people think about their risks.
And then I had a lot of questions. I don't know if you see them pop up about hormone replacement therapy. And is it protective against osteoporosis or brain health and risk of Alzheimer's? When's the best
Yeah,
time to
yeah,
start or stop using it? And what are some risks?
yeah. So it's complicated. So, for us, we don't use the words hormone replacement therapy. Like, we're such sticklers for semantics, and I'm so sorry. Hormone replacement therapy for us is for those patients who had menopause early, under 40. Everybody else is just getting hormone therapy because they don't feel well, right? And that's totally fine. Hormones are FDA approved to prevent osteoporosis, but not to treat it. But we fundamentally think that there are better options for prevention of osteoporosis than hormones. The data on brain health is messy. And I think we're going to know a lot more about it in the next 3 to 5 years. Maybe, I'm hoping that it pans out a little bit like the cardiac literature, which is probably helpful early, not helpful late. That's what the neuro literature so far looks like, that, early on is probably fine, later on, maybe increasing the risk of dementia. But I'm just going to say like messy, and that's actually how I'm counseling my patients right now. Like, probably isn't perfect. And again, the lowest amount of time we needed for the symptoms that we're taking it. We don't recommend it as a preventative. And then again, sort of the fatigue and overall well-being, we just think is related to sleep. And I can just not underestimate, I cannot underestimate risk. Sorry, importance of sleep. I see some risk stuff coming up. I'm so sorry. So I just can't underestimate the importance of sleep.
All right. And do foods and drinks that include soy affect your estrogen or hormones?
Yeah, I love this question. And I love this question because it depends on who's asking it about what the importance is, right? Um, you know, cavalierly, I will say, if you feel better, then um, it's probably got enough hormones to make you feel better. But look, in the best data that I know actually looks at really large amounts of soy protein in breast cancer survivors actually out of China, right? They're 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 eating more, even in those studies, women who have soy as their regular part of the diet was like, oh my gosh, I can't eat this much soy. And they really didn't see an impact on breast health. And so I say like all things in moderation, it's probably fine, but probably is of no specific benefit. But let me asterisk, a lot of the current over-the-counter products that say soy or yam actually do have added synthetic hormones to them right now. So be really careful about what you put into your body. It may say natural yam estrogen and have other stuff in it that is in fact synthetic, and that's why it's active. So just sort of a little bit of a word to the wise. I'm paying attention to what you're getting.
Is there a difference between the risks associated with transdermal estradiol versus taking oral estrogens?
Well done, Bree, with your estradiol. So yeah, so there is an increased risk of heart attack, stroke, and blood clot with oral. So we really do, um, for patients who need hormone therapy, we really do try to have them only on transdermal. Even patients like there are so many different formularies and there are so many different medications. I can almost always find one that helps. I get that for people who take daily medications, oral just is easier, but it really isn't as safe. And because the cardiovascular risks are the worst risks, that's why the Women's Health Initiative came out. That's why everybody kind of backed off of hormones and why we're having this discussion today. It was primarily because it was oral estrogen or oral estrogen with synthetic progestogen. And so we really do think those two are far uh, inferior to transdermal estradiol and oral progesterone.
With patients who have been prescribed the patch and may have gone off of it, have you observed an increase in this person said cholesterol, blood pressure, and migraines?
Not regularly. And so again, everybody is different, everybody's different. Um, Usually when patients come off, they actually feel fine, and that's actually like our goal. Right? That like we transition people slowly down. We do titrate people down because if we stop relatively rapidly, they will feel not as well. Um, but most people by the time we titrate them down actually can feel better off. That there gets to be a point where it's like no longer helpful to them. Um, the other half of that question is though, is that like aging is also true. And so as we get older, even if we're eating well, exercising, sleeping well, sometimes genetics just catches up with us. And we can start to see some elevations in cholesterol in particular. Now, estrogen does increase and HDL or good cholesterol, which shouldn't impact and specifically in transdermal any LDL or total cholesterol or total triglyceride measures.
Is there a recommended treatment for vaginal atrophy other than hormones?
Yeah. So we would say, I'm smiling because like cavalierly we'd say like lube for life, right? Like my chief residents all say like they're gonna get t-shirts that say lube for life. Having a good lubricant that you and your partner will consistently use and you like is really important. Um, Lubricants come in three types: water-based, silicone-based, and oil-based. Look, some women like oil-based. Some people are really happy with coconut oil. Um, but 1 in 3 postmenopausal women will find oil upsetting. So if someone's already using it and they're happy, like, cool, I'm like happy for whatever is working for them. The other thing is like, I am like a working mother. Like I want to do more laundry. Like I want like, like more work, right? So they tend to be a little bit messier. Our favorite water-based are going to be things like Astroglide. You can find that everywhere. Silicone base are a little bit harder to find, but can be truly life-changing for some women. And Uberlube is going to be our favorite. Interestingly, the New York Times had an article this week that said that was also their favorite. So we've been saying that for 10 years now. So it turns out we're just right for the New York Times. Vaginal moisturizers are also hormone-free. And here I don't really have a preference. Lavina and Replanza are going to be your two easiest to find. There's also an organic one you can usually find at Whole Foods called Good Clean Love. Those are, you're going to use them 2 to 3 times a week with, regardless of sex, just as maintenance. And so if you think about how our skin can get a little drier, it's the same with the vaginal tissue. It just keeps moisture in that tissue. It's not going to improve lubrication, but can improve comfort. And then I also do recommend vitamin E suppositories. We talked about vitamin E as a hot flash manager, which I don't tend to recommend, but I do recommend it in the vagina. And Carlson's vitamin E suppositories are really well tolerated and have been very well studied in breast cancer patients. And so you can get them online. Again, you just use 2 to 3 times a week to improve moisture in the vagina.
Do you have any recommendations on losing hair during menopause?
And global hair loss, this one has been interesting, which is to say that like we do have some patients lose hair in menopause. Sometimes our patients are like, Marsha, I'm gaining hair where I don't want it, and I have hair where I don't want it. And anyway, so honestly, for this, I do this with my dermatology colleagues. If it's patchy, we do need to look for an autoimmune cause, and if it's just general thinning and there are no vitamin D or iron causes or anemia causes, then actually things like Rogaine can be really helpful. I do rely on my dermatologic colleagues here to make sure that we are doing the right thing by patients. The other thing that I say is a little bit tricky is that in COVID, we have seen some pretty significant delayed hair loss that does regrow after having been sick. So people have been sick with COVID, and then a couple of months later, they'll report like massive hair losses. That does come back, but that has been, I would say, newer in our practice compared to sort of like, sort of our other baseline menopause.
Are longer periods and shorter cycles normal for someone in perimenopause?
Yeah. So yes, and right. So here's what we will accept. Any cycle that is day 1 to day 1, so first day of bleeding to first day of bleeding, that's over 21 days. Under 21 days, we can't really ovulate that fast. So if your day 1 to day 1 is under 21 days, you should see your gynecologist. So it's actually probably okay. After that, any bleeding, look, we say up to 10 days, but really shouldn't see much more than 7. So any bleeding more than 10 days, you should call us. And then any bleeding where you're soaking a pad an hour or a tampon an hour for a couple of hours, that's also not helpful. And there are many causes. It could be polyps, could be fibroids, could be adenomyosis, could be anovulation. And so each of those treatments are really different. So if your bleeding falls outside of those parameters, then you should see your provider. If your bleeding falls inside those parameters, then it's actually fine. You can, if you're someone who can take ibuprofen, or people can take ibuprofen, cyclic round-the-clock ibuprofen, starting with the first beginning of bleeding, will actually decrease menstrual bleeding by 30%. Super simple. You can have it anywhere. But just make sure you're somebody who doesn't have any GI contraindications or reasons that they can't take Advil.
If someone has joint pain due to perimenopause, do you recommend they see their PCP or OBGYN?
What a good question. My answer is both, right? I always just like to make sure it's me, right? And look, there are no FDA approved treatments for joint pain. But if I think it's menopausal by history, I do use estrogen. And if it gets better, then it was me. And if it wasn't better, it's not me. So I think it's worth seeing. We also do see, and the why I say it's complicated, we also do start to see increased autoimmune disorders around the menopausal transition rate. So we see them at pregnancy, post-pregnancy, and then we see them again at menopause. And if there are any of my immunology colleagues on the line, if they're not mad at me for kind of simplifying it that way, but that's how it impacts my life. So just making sure that we aren't, I'm not missing rheumatoid arthritis, or I'm not missing psoriatic arthritis, because those are really life-changing and important otherwise for your health. And so my sort of cavalier answer is sort of both.
And I will pause for a moment. I know it is 1 o'clock, so we're out of time. We do have about 5 or 6 questions left, so we'll stay on and keep going through those. But if you have to drop off, thank you so much for joining us. And we hope we'll see you at one of our upcoming group chats. The next 2 topics are migraine management and birth control planning. So thank you for joining. And so go through these last few questions. All right.
Yeah,
Our
trying to move as fast as I can.
yeah, you're doing good. Are treatment recommendations different for people with type 2 diabetes going through perimenopause?
Yeah, perimenopause can be a little bit challenging because some of the hormonal contraception depends on sort of what your control is and any other risk factors. So um, there is something called the CDC medical eligibility criteria for contraceptive use. And so that's something I rely on really heavily. And so that's part of shared decision making. We would pull that up and sort of figure out if that's the right for you. Otherwise, non-hormonal options are totally reasonable.
If prostate cancer and breast cancer run in a family, is the risk for gynecologic cancer increased?
Depends on which relatives, and depends on the age. Prostate cancer in general, no, unless it was metastatic. We think of metastatic prostate cancer as being something different. So metastatic prostate cancer is more likely to be associated with high-risk breast and ovarian cancer genes. And then breast cancer, again, like 1 in 8 women will have breast cancer. So most of us will have someone in our family with breast cancer. It just depends on what age they were. Under 50 is really different, whether they were first degree or second degree relative and how many of those first or second degree relatives there were. So it's not it deserves an actual discussion about who and what was and when.
Mm-hmm. Are there risks with taking a weight loss drug while on hormone treatment?
You know, this is a super interesting question, and it's new, right? And so we don't know. We don't know. I am certainly not counseling people with hormone therapy any differently if they need a GLP-1. And I have not seen any impact currently with my patients who are doing both. We don't know, right? And I think more data to come. At this point, I have no contraindication to doing that, but again, it's something that we would just talk about every year. But right now, I don't have any reason to say no.
If someone has been on the patch to treat hot flashes, night sweats, and mood swings/fatigue, about how long can they expect to be taking this treatment?
Yeah, so this is shared decision making. Sort of depends about the age and menopause and the degree of symptoms when we started. I'll start to try to transition people down their doses in their late 50s, and see if I can really get people off by their early 60s. Again, this is just about breast cancer risk, and so 3 to 5 years would be sort of standard duration of use, but we just do it as a discussion. But 3 to 5 years is what you'll see basically in the literature.
All right. And then last question, should I steer clear of over-the-counter supplements such as estrogen?
Yeah, I think again, if it doesn't work, you just spent your money for no reason. If it does work, there's something in it and we don't know what it is, right? And so, and that's not speaking about estrogen itself. I don't, I think all supplements with caution. The other thing about supplements is that, because they're not regulated, people are taking a lot of them. We do see real deal liver damage with them because of the additives and things that are in the supplements. So I think it's really worth taking like a risk benefit calculation, reviewing the specific medication. I pull up the ingredients list with my patients for individual medications and taking a look at them. But even every brand, I mean, estrogen per se is an old medication, but I don't know which version of estrogen. There's so many. And so really looking at the list of what those what's ingredients are, and I'm happy to do that with my patients to go by one through those ingredients and see what they are.
All right. Thank you so much, everyone, for joining. Thank you, Dr. Kondatel, for your time and expertise. That was wonderful.
All right. Thanks, everyone. Have a wonderful day and enjoy the summer.